which is a very important complication, which has not received adequate attention, and I think it is my duty to attract your attention to the importance of this condition. Now, before I start, I must again emphasize that the key pathogenic mechanism is again insulin resistance. So that is the key enemy which leads to all the problems. And let us therefore start by looking at the fact whether diabetics have a higher prevalence of fatty liver disease in all forms. And the yellow bar I have shown are the diabetics comparing with the general population shown in blue bars. So fatty liver disease, 60% in diabetics and about 20-24%, because the figures in India are variably described as between 10 to 32%. So I have taken an average figure of around 20-24%. But if you look at NASH figures, the NASH in general population is about 4 to 5%, whereas in the diabetics it goes up significantly to 20% or 24%. So that is a very important observation, and it needs a lot of attention, which I'll be showing subsequently. And cirrhosis, again, at least doubling or tripling of the risk for developing cirrhosis in patients with diabetes. Now, this is just to show the natural evolution of fatty liver disease. The fatty liver is predominantly a benign problem with less than 2% risk of developing cirrhosis of the liver. But once they develop steatohepatitis, which means in addition to the fat, there is deposition of inflammatory cells and development of fibrosis. Once you have NASH, then look at the figures there. 30 to 50% of them are going to develop fibrosis, and over a period of 15 years or so, about 20% are going to develop cirrhosis of the liver. So we have a long period of 15 years, mind you, in order to detect the disease, prevent progression, and prevent patients having cirrhosis of the liver. Because cirrhosis, once it happens, not only leads to the end-stage disease, but also is a high risk for development of hepatocellular carcinoma. And that is also something we must bear in mind. So if you put that in numbers, today the number of diabetics in India is about 60 million, and 60% prevalence means there will be 36 million diabetics with fatty liver disease, and about 7 million or more with NASH. And that is a crucial, aspect of fatty liver disease, because that means maybe progressive disease there, and 15 to 20% if they develop cirrhosis, we are talking about more than 1.4 million diabetics with cirrhosis over a period of time. So this is a major problem, and I think the crucial aspect is to catch the patients, the ones who have NASH, and treat them aggressively before they develop progressive disease and development of cirrhosis. Now, people ask the question, why treat fatty liver at all? Because we see them day in and day out in our clinical practice. Well, because they have 1.7-fold increase in mortality. They are not only mortality related to liver disease, but they are the cardiac risk factor as well. So they must be seen not only from the liver standpoint, but also as a marker of cardiovascular risk. And why should NASH be the therapeutic target? I've been talking about make sure you pick up patients who have got NASH. Well, because NASH has 10-fold increased risk of liver-related death and doubling of the cardiovascular death. And therefore, it's certainly a very important stage in the spectrum. Almost 1/3 of the patients with NASH will have advanced fibrosis, and about 40% of them will continue to have progressive disease. So I keep harping on the point make sure in clinical practice you pick up patients who have got steatohepatitis or NASH. And how would we do that in clinical practice? Well, let us take some clues of the evidence we have got. And this is the SPRINT study. Some of the authors are probably sitting here. Prevalence of fatty liver disease in this study was 56.5%, and the mean AST/ALT level was 54 and 56. So what does that tell us? Well, it tells us that a patient with metabolic syndrome, even with a mild elevation of SGOT, SGPT, is a risk factor for fatty liver disease and should not be taken lightly at all. A significant proportion of them are likely to have NASH, and therefore early detection and treatment is of utmost importance. How do we diagnose NASH then? Well, we have non-invasive markers, and there has been a huge amount of work with about 50 different types of markers, but none of them have gained popularity. FibroScan has become certainly more popular now, and liver biopsy remains the gold standard, but Indian patients are not very happy, or Asian patients also, for getting a liver biopsy done. So this is the fibrosis score, and these are some of the features which suggest that the patient may have NASH or fibrosis. Age, obesity, presence of hyperglycemia, low albumin, low platelet count. And many a times you find in clinical practice an individual who has got just low platelet count, who is being investigated for hematological disorder. We forget that these patients may have liver disease. And those who have a high SGOT-SGPT ratio, it is not only the alcoholics, because the ratio is very high in alcoholics. It is more than 2:1. Minor degrees of SGOT-SGPT elevation and ratio elevation is present in any patient who has fibrosis of severe degree or cirrhosis. Now this is the WHO guideline that if we want to assess the severity of fibrosis or cirrhosis, the ideal system is liver biopsy and various forms of staging of the disease. What I have shown here is Metavir's scoring system, which is one of the most popular. But liver biopsies in low-income countries are infrequent because high cost is there, invasiveness is there, and the need for expert interpretation. So once we tell the patient that doing a liver biopsy, there is a small risk of bleeding, and occasional death has also been reported. That's the end of the procedure. Patients do not come for the procedure. Now, newer techniques like FibroScan have been extensively evaluated and found to be useful in this situation. So, FibroScan is useful, but the cost is there, the availability is there. How many people have access to FibroScan? Very few actually, and in the rural areas there is no FibroScan. So what should we do? Because patients are not only there in the urban centers and in the metropolis, they are all over India, and 70 to 80% of Indians are living in rural areas. So this is again WHO 2015 recommendation. Simple blood tests such as ALT and AST and platelet count can be done anywhere. And based on this, you have the APRI scoring. These are simple formulas. This is AST platelet ratio index. And based on that, you can have a score. If the score is high, you know that this patient is a high risk for fibrosis or cirrhosis. And similarly, there is this FIB4, which takes into account the age, AST, ALT, and platelet count. So these are simple features which you can use in order to decide whether the patient is a high risk for fibrosis. Therefore, in resource-limited setting, use this as a non-invasive marker, although FibroScan will be more accurate. And FibroScan has been validated against the standard histological staging and certainly is advantageous. So the diagnosis of NASH I have shown here Here is a patient who has got mildly elevated also SGOT, SGPT. Look for evidence of features of metabolic syndrome, such as diabetes, dyslipidemia, etc. Exclude alcohol use. This is very important. And all patients must have a hepatitis B and a hepatitis C testing, which is again very simple to do. It is available in most places now. Therefore, exclude that. And clearly you require a simple ultrasound to show whether the liver is fatty or not. And once you have that, you have two options. If you have access to FibroScan, go ahead. If you do not have, use APRI, use FIB4, etc. And if you then have to decide whether the patient has got NASH or no. And that is a very practical guideline. And once you have made a diagnosis, you have to treat them aggressively. And the various focus of treatment has been shown here. Lifestyle modification is the most important. It is the most important. Then you target components of metabolic syndrome. Treat the hypertension, diabetes, dyslipidemia. And then there are certain liver-related pharmacotherapy, and in the worst scenario, you will just be managing the complications. Now, just to again emphasize, diet and exercise are the most important. Without any other drugs, you can reduce ALT levels, you can reduce BMI, you can improve the HOMA scores, and not only that, if you look at the right side, you will cause improvement in histology of the liver as well. Therefore, diet and exercise remains the mainstay of treatment. As far as drugs are concerned, well, let me be very clear. As of now, there are no approved drugs for treatment of NASH. But many drugs have been extensively evaluated. We have got a lot of evidence with vitamin E, pioglitazone, which is insulin sensitization, anti-inflammatory methodology. Drugs like metformin we know are useful, and statins, angiotensin receptor blockers like telmisartan, olmesartan, losartan have all been studied and found to be useful, although we still require larger studies. And lastly, pentoxifylline is also a drug which has been used. It is used more commonly in the alcoholic hepatitis, and patients, particularly those who had marked inflammatory features such as an increase in TNF-alpha, have benefited from pentoxifylline. But again, larger studies are required. And then there are many other drugs. In fact, now the mainstay and focus of drug development is on two. One is insulin resistance, and the other is inflammation, as was being shown by Dr. Munjal earlier, that use of aspirin. So inflammation is another target, and drugs like saroglitazar, etc. have all been tried and probably will come out clean. But the drug which appears to have promise as of now is obeticholic acid, which is a bile acid. It is a farnesoid X receptor agonist, improves insulin sensitivity, reduces inflammation, and in this study which was published in Lancet in 2015, this was a 72-week trial on a large number of patients. There was significant improvement, including improvement in fibrosis. This was also associated with weight loss and improvement in SGOT and SGPT. However, there was some rise in the total cholesterol and HDL levels, and the worst thing in fact was that 1/4 of the patients developed pruritus, although most of them could be controlled with simple measures. So we still have a long way to go, but this drug appears to be the most promising as of now. Saroglitazar has already been mentioned. Liraglutide, evidence emerging again that it causes reversal of fibrosis and therefore may come out to be an important drug. So I will close the chapter of NASH with just this sort of management plan. Lifestyle modification, control aspects of metabolic syndrome. And for those who have hypertension, angiotensin receptor antagonists are the drug of choice. For those with insulin resistance and diabetes, metformin, which has also been shown to reduce hepatocellular carcinoma risk. And for those with dyslipidemia, statins, because again they are safe, CVD risk is reduced, and there is some evidence to suggest that fibrosis is reversed as well. And then lastly, you have liver-directed pharmacotherapy, no approved drugs, but we are using a lot of vitamin E in a high dose, but it is not safe in the long term because there are reports of prostate carcinoma, increase in all-cause mortality, and increase in hemorrhagic strokes as well. So that is not a panacea certainly, and we need more work. We need a drug which is approved for treatment of NASH. Now what about diabetes and cirrhosis? Well, cirrhosis is a major problem which we have to deal with. And it is one of the top 10 causes of death. And look at the figure there, almost 1/5 of the global liver cirrhosis deaths are occurring here in India. And therefore, it is a major problem. And the worst thing is that there is a 30% increase in mortality due to cirrhosis between 1980 and 2010. And why? One of the most important things is increasing prevalence of diabetes, which is a major risk factor for fatty liver disease. There is also increased alcohol consumption in India, and we are also seeing hepatitis B and C, particularly C we are seeing more now. So, the relationship between diabetes and cirrhosis of the liver is bidirectional. So, a diabetic has a higher risk of developing cirrhosis, and a cirrhotic has a higher risk of developing diabetes. And this is a large veteran study which was actually a retrospective study, but very well accepted because it has a large number of patients, something to the tune of about 2 lakh diabetics and about 6 lakh non-diabetic patients who were followed up for 10 years or so. And the incidence of non-alcoholic chronic liver disease and hepatocellular carcinoma was significantly increased in patients with diabetes. So certainly diabetes is a risk factor for development, and the risk was at least 2-fold higher and was independent of the other causes of liver disease. Now, diabetes also increases the morbidity and mortality of liver cirrhosis patients, and if you look at the Verona study of more than 7,000 individuals, the risk of death at 5 years was 2.5 times greater than in the general population. And there is also another interesting thing, that presence of diabetes has been shown to produce more severe fibrosis in patients with hepatitis C. So actually there is evidence emerging that diabetes is an extrahepatic manifestation of hepatitis C, which has some direct action on the liver cells causing insulin resistance. And if you look at this data here, patients with hepatitis C, those who had diabetes, had a much higher prevalence of hepatocellular carcinoma compared to non-diabetics. So hepatocellular carcinoma risk increases in patients with HCV who have diabetes. Now, liver failure is higher in diabetic patients compared to non-diabetics. Survival in patients with refractory ascites is lower in diabetics as compared to non-diabetics, as shown in this slide. And 1-year hepatic encephalopathy episodes in cirrhotics is also much higher in diabetics. So they cause worsening of the complication, increase in morbidity, increase in mortality. What about the other way around? What about diabetes in patients who have got cirrhosis? Well, up to 96% of the cirrhotics may be glucose intolerant. So glucose intolerance is common. 30% of patients with cirrhosis will have diabetes mellitus. So that is the other way around. So it is a risk factor for cirrhosis, and again the key pathogenic mechanism is insulin resistance, hyperinsulinemia. So other problem is in the diagnosis, because clinical manifestations of diabetes is virtually absent, and therefore unless you are really looking for it, you are likely to miss diabetes. And about 40% of the patients' diabetes is subclinical. What does that mean? If you do just a fasting blood sugar level, they may be normal. So you may not be able to pick up unless you go ahead with a postprandial and a HbA1c, etc. The incidence of frank diabetes increases as the liver function deteriorates. Therefore, once a cirrhotic develops diabetes, diabetes is considered a marker of liver failure. Now the problem is that we should be able to detect them early and prevent development of cirrhosis, but most often patients are detected when they present with symptoms. And what are the symptoms they present with? They present with ascites, GI bleed, jaundice, and encephalopathy. So it is a decompensation which leads to presentation to the doctor. But by the time they have presented, I think it's too late. Because if you look here, once there is decompensation, the median survival is less than 2 years. Whereas if you pick up a patient with compensated cirrhosis, the median survival is 9 years. So the idea is to detect the cases before they decompensate. And how would you improve the outcome then? So if you have picked up a patient with cirrhosis and he's got diabetes, what would you do? Well, nutrition is one very important factor. And I will just, there is a lecture on nutrition again tomorrow, but I will just touch on it because I think there's a lot of myth about nutrition in patients with cirrhosis. And treatment of diabetes, optimizing treatment of diabetes is very important. And if you have a patient with decompensation, which means they've already presented with jaundice, ascites, encephalopathy, bleeding, then ensure that you take certain measures which prevent complications, prevent progression of disease, and the measures are reduce the portal pressure by using non-selective beta blockers such as propranolol or using the endoscopic variceal ligation. Prevent infection, which is another very important killer. And most important is preventing spontaneous bacterial peritonitis. How do you do that? Well, it is recommended that patients who have the ascitic fluid protein which is less than 1.5 or a serum creatinine more than 1.2 should have prophylactic antibiotics. Very simple treatment. You can put them on simple norfloxacillin or something, and that would prevent to a large extent. And again, nutrition and treatment of the underlying condition remains important. Now, nutrition, I'm not going to go into any details, but one of the problems we see in clinical practice is once a patient has been diagnosed as cirrhosis, they are asked to go on boiled food, etc., etc. Energy, nutrition is of extreme importance. There are lots of malnutrition, and replacement with vitamins, zinc, multivitamin, vitamin D supplementation are all important. The other myth is the protein restriction myth. The moment patient is diagnosed, we restrict the protein. Let's be very clear that the protein requirement in such patients is high. Chronic protein restriction is detrimental, and it leads to further development of hepatic encephalopathy. And if low protein nutrition should be avoided, and milk-based protein or vegetarian proteins are preferable over animal proteins. And for patients who do not tolerate normal proteins, one can use the oral branch-chain amino acids. Now, I think this is about the last thing which we are going to talk about is what about treatment of diabetes, in patients who got cirrhosis. And I'm no diabetologist, so I'm not qualified or competent. I certainly take help with my diabetologist colleagues. But the problem I would like to focus on is that most of these patients have malnutrition. By the time diabetes is diagnosed, they have advanced disease, and most of the oral hypoglycemic agents are metabolized in the liver, and since liver is not functioning, there is a higher level of the drug leading to more problem with hypoglycemia, and therefore that becomes important. Therefore close monitoring of blood sugar is required, and biguanides, again, metformin is a very important drug and can be used in early cases. However, it is relatively contraindicated in patients with advanced renal failure or those who continue to take lots of alcohol because of risk of lactic acidosis. But in child's A, early B, metformin can be used. And there is good evidence to suggest that metformin used in patients with cirrhosis, there is a significant reduction in the incidence of hepatocellular carcinoma, and on the right side, they have shown a significant reduction in mortality. Therefore, metformin remains a useful drug. Other drugs are sulfonylurea, valcaution, again with advanced cirrhosis. Second generation drugs such as glipizide, glyburide and glimepiride are probably the drugs of choice, but glyclazide is extensively metabolized in the liver and contraindicated in severe hepatic insufficiency. Other drugs, I will not go into details, but alpha glucosidase inhibitors, pioglitazone has gone through ups and downs. Avoid if ALT is more than 2.5 times the upper limit of normal. DPP-4 inhibitors and GLP-1 receptor agonists can all be used with caution. Insulin, well again, many patients with advanced cirrhosis and other complications will require insulin, but their insulin requirement is low and there is always a risk of hypoglycemia. Therefore, short-acting insulin in small doses should be given. Bariatric surgery for patients who are cirrhosis, diabetes and obese. Well, surgery is relative contraindication in patients with cirrhosis. However, it may be performed in child A cirrhosis, which is early cirrhosis, and that improves diabetes in up to 70% of cases. So yes, if it is early cirrhosis, it can be done. What about liver transplantation? This rapidly normalizes glucose tolerance and insulin sensitivity, and it improves diabetes in about 2/3 of the patients. However, 1/3 of the patients they remain diabetic because probably they have got significant reduced beta cell function, and therefore they remain diabetic. Just a word about the evolving therapies, statins, stem cells, antifibrotics, etc. And I would just like to point out to 3 things over here. Simple measures which can cause a reversal of fibrosis, or at least partial reversal of fibrosis. One is the turmeric. The active ingredient is called curcumin, and it has been shown that curcumin can regress fibrosis in patients with fatty liver disease. Probiotics. Again, there are studies with VSL, number 3, showing that there is a significant improvement. But all these require larger studies. And lastly, coffee. The South Indians in particular are very clever. They have lots of haldi, they have lots of dahi, and they have lots of coffee. And it has been shown that if you have 3 or more cups of coffee, you can actually protect yourself from progression of not only fatty liver, but may lead to some regression of fibrosis as well. In summary, in fact, instead of summarizing, because I think I have made things pretty clear, what I would like to end with is a very important message. And the message is that any protocol for screening of diabetic complications, I think diabetic hepatopathy needs to be there. Mostly it is not there at all in the list, because if we continue to monitor investigate these patients, particularly those with long-standing diabetics, we will pick up a large number of NASH patients and we can prevent progression of the disease. Thank you very much.
Thank you very much. Highlighted topic that it is said that every third person who is going to have liver transplant belongs to this category of disease. So it is a burning topic at present. You know, our concentration ought to be to detect the fatty liver, non-alcoholic fatty liver. Once it's added to NASH, then it becomes very problematic. What he has said about the coffee and other things, I think we should practice. Thank you very much for such a nice lecture in a topic which is a very recent one. It has just come in this Sherlock Holmes hepatopathy. This was added in 2012. So it is such a new thing, and you see the killer of so much high that every third person is going to have liver transplant for these things. Thank you very much, Doctor.
Patience is good, but not to test the patience beyond a certain limit that it breaks. Therefore, I think in the business of things, I think we will conclude our scientific session here today and start a little early in the morning. Therefore, with this, I would like to thank all the participants for being there, and may I request the chairperson, Dr. Mehta. Dr. Mehta, please present a memento to Dr. Rajesh Upadhyay. Dr. Maji Radha Satwan. Ladies and gentlemen, I think